you are pregnant until proven otherwise. When you're not having success, here's things that I think about. I rarely do a fresh transfer. If we miss that window, we're going to have lower chance of success. Progesterone, again, is crucial for implantation, so we've got to get levels high enough. It allows us to have better synchrony between the uterus and between the endometrial lining. We expect 2 to 3 months, and there's nuances to this. And that sometimes is where I see that people lose their way. We want to get the outcome of the cycle faster so we can get on with that next one. Welcome back to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and today we're diving into a moment that holds a lot of hope, but also so much fear and many questions if you're going through IVF, the embryo transfer. For many people, the transfer feels like the finish line for IVF. It's the moment when all the shots, ultrasounds, and maybe years of trying finally come together. But the truth is, the transfer is its own process with specific preparation, protocols, and expectations. And this can either feel empowering or very overwhelming. So I want to take the confusion out of this for you. In today's episode, we're going to break down what actually happens during the embryo transfer, the difference in a fresh and frozen transfer, including different protocols for medications, and how you should prepare physically, hormonally, and emotionally. And when you don't have implantation, what you should do. My goal is to give you a clear evidence-based roadmap so you can walk into your embryo transfer feeling informed, supported, and confident, and not scared or guessing. So let's dive in. Hi, friends, and welcome back. Today, we're talking all about embryo transfer, as you know, and this is something that I think very many patients are not quite prepared for. And this makes a lot of sense because you're so focused on IVF, getting eggs and egg quality and making embryos and waiting on those genetic results that often the transfer is an afterthought. But the truth is the embryo transfer, it's actually my very favorite part of everything that I do. It's such an important moment and there's a lot of nuance to it. So today I just want to break down what to expect, some of the differences, and put you in a position of power. So let's think about the embryo transfer and start with the difference in fresh and frozen transfers, because this has changed throughout my time in the field. When I first became a fertility doctor, most of the transfers we did were fresh transfers. So we think through the IVF process. I want to remind you that when you're going through IVF or in vitro fertilization, we're getting a group of eggs. We're taking these eggs out of your body, fertilizing them with sperm in the lab. That's the fertilization part. And then they are growing in the lab as embryos. And they have to grow to a certain stage of development. And that's typically day 5 or 6, known as the blastocyst stage. At this stage, they are the implantation stage. So a fresh transfer means we put this embryo back in your body immediately. This is because it is the right number of days after ovulation. And remember that inside the uterus, the endometrium only has a set number of days where it can accept an embryo. This is the implantation window. And it's all based on progesterone. After you ovulate, you make progesterone. Progesterone opens and closes the implantation window. So at the 5th day, if we consider the egg retrieval day 0, you have 1, 2, 3, 4, 5. On day 5, the uterus is ready, and you can now take an embryo and put it inside the body. Well, the nuance here is that some patients actually do better with frozen embryo transfers, and the field has shifted immensely, whereas now I rarely do a fresh transfer. And I'll explain why. It's never, but it is definitely something that has switched as technology has improved. We feel more comfortable freezing and thawing embryos. And it really does allow us to get more synchrony between the endometrium and the embryo. And the reality is that the IVF process of growing multiple eggs is not a normal hormonal environment for the inside of the uterus. When we think about this, remember what's happening naturally. You are growing one egg, your estrogen would peak around 200 picograms, your follicle would rupture, the egg would be released, and then that follicle is going to reform and become the corpus luteum and make progesterone. Well, in this scenario, that progesterone opens and closes the implantation window, but your uterus was only exposed to a set amount of estrogen. It's around a peak of 200. Well, if each mature egg makes around 200, what happens in IVF when you have 20 mature eggs? Your estrogen is going to be 20 times higher, and that absolutely changes the integrity of the endometrial lining. In addition to seeing lower pregnancy rates with a lot of fresh transfers, we also saw higher risks of ovarian hyperstimulation syndrome, or OHSS. It doesn't give you the opportunity for genetic testing in most circumstances. And there's also different fetal outcomes and risks. So let's walk through these. So fresh transfer means you put the embryo in right away. We can see dyssynchrony between the uterine lining and the embryo because you have to put the embryo in on that day. Sometimes embryos take an extra day to develop, those day 6 embryos, but they wouldn't be ready when the uterus was in a fresh cycle. You also can see that early progesterone exposure because sometimes when you have multiple mature eggs, you're preventing ovulation with some of the medications for IVF. This can actually cause progesterone to be released earlier in an IVF cycle. And I actually did research in fellowship showing that progesterone levels on day of trigger were correlated with success rates in fresh transfers, meaning the higher it was, the worse your pregnancy rates were. And that's in patients who maybe got wonderful embryos. So we can see dyssynchrony between either growth of the embryo or stage of the endometrial lining. We also then can see that ovarian hyperstimulation. OHSS is when your body has such high estrogen levels that it changes the integrity of how your cells are functioning. Estrogen can destabilize the blood vessels and cause what we call third spacing of fluid. So the water vascular component of your blood migrates outward, and you can get fluid on your lungs, your abdomen, your legs. But inside your blood, it's very thick. And this can cause problems because inside your blood vessels, the blood is really thick. This can lead to kidney damage. It also can lead to blood clotting, like a deep vein thrombosis. So we're in a position where that can actually lead you to get really sick. When you have OHSS from the high estrogen, it typically will be resolved quite quickly. But the big caveat and exception is when your body has HCG. So when you get an HCG trigger, you're at higher risk of developing OHSS. Remember that in IVF cycles, some protocols could let you do Lupron for the trigger. But if you get pregnant, what's the pregnancy hormone? It's HCG. And suddenly now, as HCG is rising, you're stimulating that ovary to continue and make hormones, and you're going to be in a position where OHSS may not end. And I've had patients hospitalized and very sick. They might need procedures to remove fluid. And again, this was more than a decade ago because we really do not see OHSS anymore. But it's a risk with a fresh transfer. And then we can see higher rates of problems with the baby. And this is because of the placenta growing into this abnormal hormonal environment. We see higher rates of preterm birth, small babies, preeclampsia, and this is all a placental invasion issue that is diminished when we have a frozen embryo transfer for the most part. Now we see larger gestational age. We see babies that are not being delivered preterm. We have lower rates of placental issues like preeclampsia. So a frozen embryo transfer is now safer for baby. It's safer for mom. It allows us to have better synchrony between the uterus and between the endometrial lining. So in most scenarios, that is what people are doing now. And that's what we'll talk about for the rest of this episode. When do we do a fresh transfer then? Well, it is faster. In somebody who has a very low egg count, who doesn't need genetic testing, it might give us the opportunity to move more progressively through an embryo transfer if we have a high index of belief that the embryo is genetically normal. Remember that as you get older, the embryos have a higher chance of being genetically abnormal. As a patient, we think of a cycle as it'll work or it won't. But one of the worst scenarios is having a pregnancy loss that can drag on, especially if you are older or have lower egg count. We want to get the outcome of the cycle faster so we can get on with that next one. So that is not always the best scenario if we have a high risk of aneuploidy. So it's a very limited patient population who might be a good candidate for a fresh transfer. Many of patients, even in that group, really want genetic results. They're trying to bank embryos or think about their future. So it is a rare day where I'm doing a fresh transfer now. So when it comes to a frozen transfer, what's happening is those embryos are now frozen at that day 5 or 6 state. Nice thing here is we can let them get to this perfect implantation state and then freeze them. And then when we thaw them, we can put them in on what would mimic day 5 of the uterus. So that's how it's improving that endometrial synchronicity. We also have such improvement in how we freeze and thaw embryos. So embryo freezing and thawing technology is now to the place where 98 to 99% of embryos are going to survive the freeze thaw if they're frozen at the blastocyst state with vitrification or the current modern freezing. So for that 1 to 2% chance, we now have greater benefit by avoiding all of these other risks and by optimizing the uterine environment with the embryo. So it's not quite as straightforward. I understand many patients ask for a fresh transfer for time. They want to be pregnant yesterday. But truly, many times a frozen really is best. So when we freeze the embryos, we are now waiting. So you have to bleed off that lining that grew in the IVF cycle. And now we have to regrow the lining. And this is where we want to think about the different embryo transfer protocols. So when it comes to the protocol, this is what we are going to do to get the lining to that perfect implantation stage. And this is how I explain it to my patients. I like to think there's 5 different options for what we could do, and we can think about them in level of aggressiveness from most natural to most optimized medically. And there's not one that's better than the other for everybody, or I would sit here and say, this is what we do. What we want to do is personalize this for you and what's going on in your circumstance. So the most natural is going to be what we call a natural cycle. You grow a follicle on your own with no medications. We track ovulation. Your body makes progesterone, and we time putting the embryo in at the perfect time. There's some nuance about how do we know that timing is perfect. We really have to have the ability to track you well to know when progesterone first starts to rise, because if we miss that window, we're going to have lower chance of success. One step up from there is going to be what we call a modified natural cycle. And this is the same idea, meaning you're going to grow an egg. That egg will make estrogen. That estrogen will grow the lining, and then you'll be in a place to ovulate and make progesterone. But we want to control this a little bit more, so we tend to give ovulation induction medications. This is typically either letrozole or gonadotropins themselves, injectable FSH. Monitor the follicle growth with ultrasound. Trigger sometimes with an HCG shot so we get that ovulation to occur, and then we can know exactly when progesterone is going to be made. And from there, we often can give some extra progesterone. This is typically vaginally because you have a corpus luteum and you're making some progesterone, so I don't have to replace everything. Next up, the middle of this spectrum of transfers is going to be what we call a controlled or medicated. So in this transfer protocol, we are going to grow the lining with estrogen. So I'm going to give you estrogen, and this can be in the form of pills, patches, injections, can be vaginal. And then we're going to monitor and make sure we like the lining thickness. Once we like it, we are going to give progesterone, and we need to have some injectable progesterone. At least here in the US, we need intramuscular progesterone either daily or in combination with vaginal progesterone on an every other day spectrum. But you've got to have some. And that is because the estrogen we're giving you is suppressing the ovaries. The ovaries are not making hormones, therefore you have zero progesterone. And I'm not just supplementing, I have to replace. And progesterone, again, is crucial for implantation, so we've got to get levels high enough. The nice thing about this protocol is unlike a modified natural or natural, where I'm at the will of your body, in a natural, I don't know when you'll ovulate. If I don't like the lining, if it's not thick enough on the day you ovulate, I don't really have any options. But in a medicated or controlled, if I don't love how the lining looks, I can usually extend. I can give more estrogen. I can change how we're administering it and really optimize the timeline. Also for controlling people, it is good for somebody like me because I can get a calendar. I have less overall appointments. I have a better idea of when to expect. So it's just different. One step up from there is going to be a controlled or medicated cycle with Lupron. So step number 3, we're going to say, I'm just giving you estrogen. In number 4, we are going to suppress with Lupron as well. And Lupron is going to additionally suppress the ovaries so they really don't make any hormones. Estrogen usually suppresses everybody, but not always. But Lupron has the added benefit of suppressing endometriosis or adenomyosis or other inflammation. For anybody who potentially has any of those circumstances, Lupron is a great option because we know it's taking care of some of them. And there's nuances to this. It can be daily injectable Lupron, can be Lupron for 30 days. It can be for a month or 2 months or 3 months beforehand. And then in that circumstance, we tend to give it in a different format. And that leads us to option number 5, which most of us consider the recurrent implantation failure protocol. And this is when we really want to change the uterine environment. In this circumstance, we're saying something is happening that's preventing implantation, and we want to come in and try to modify your environment. And typically, that's some type of inflammatory disease. In this circumstance, we're giving you longer Lupron or other suppressants before we grow the lining. So this could be 1 to 3 months of Lupron alone. It could be Lupron with letrozole. It could be Orlissa. There's different medications we can use, but we're really trying to change your internal cellular environment. And then we grow the lining with estrogen, go on to use progesterone intramuscularly. And then the last thing I want to say is that sometimes that Lupron can actually last for much longer than just that 1 month when we're growing the lining. And if we don't have success, we can go into a different type of cycle or a modified natural. One of the hard things is that if I've really suppressed your body with Lupron for a prolonged period of time, it might be hard to get the ovaries to respond immediately in a natural cycle. But sometimes we can get them to respond with medications. So there's always nuance and caveats between them, but what I want you to hear is that there's a lot of difference. And one of the things that I hate is when I see somebody come in for recurrent implantation failure and I look through their treatment cycles And they've done the same protocol every single time without any changes, any additional testing or thought or consideration. But that doesn't mean that the first transfer protocol will always work or that you always have to change it. And that can be really hard for patients, including me. When we look at the rates of success with an embryo, a single genetically normal embryo has a rate of success of about 65% live birth rate, which means most everyone, but not everybody. It's the majority, but there's still a big group of people who everything will be perfect. The embryo will be perfect, the lining will be perfect, and you will not get pregnant. And that is because of the embryo largely. But there could be some maternal environment that's at play. So this is a balance with when do we think it's the protocol, when do we think it's the embryo. If we don't change the protocol and we do the second transfer, we tend to see that a cumulative rate of live birth is going to be 83%, which is really great. After 3 euploid embryos, it's going to be 93%. And then after 4, it's going to be 95%. After 5, it gets closer to 97, 98%. So we know that at time, giving more embryos can be a huge thing that can prevent recurrent implantation failure, but it's really hard to have that many embryos, and we have to start thinking about this sooner. Certainly after 3 transfers with a failed euploid embryo, I want to switch protocols. To be fair, we're usually discussing this after 2, or at least thinking about what else could be going on. And so there's not a one-size-fits-all. In general, here is my thought for protocols. Natural cycle and modified natural cycle, they're much easier on your body. Many people prefer them because you don't have to use an intramuscular progesterone. If you've had a baby before, or your reason for infertility is clearly identified, and it's maybe tubal factor, male factor, you're doing IVF for genetic testing, those are circumstances where I love considering a natural or modified natural first. For my patients who have unexplained endometriosis, adenomyosis, I love adding Lupron into a protocol. And that's typically a controlled or medicated, but it could be Lupron first and then a modified natural or a number 5 recurrent implantation failure if you've had a lot of pregnancy loss that you're coming into this with. If you have known endometriosis, you've got known autoimmune issues, I'm usually quicker to add in Lupron or other things that I know will optimize our environment. So you'll hear a lot of personalization based on your circumstance. If you've had a baby before or not, if you've had pregnancy losses before or not. How did your lining look in your IVF cycle? If you had a thin lining, we're often needing a natural or modified natural cycle to get a thicker lining because the uterus tends to respond better to your natural estrogen made from the ovaries in the majority of people. So there's a lot of nuance here. I think what's important for you to understand is that we often don't change after one failed cycle, but we should always be looking at it and making sure we did like that protocol. We should be thinking about if we should make any changes or if that was optimized. And we should always know if this doesn't work, what's my next step? And maybe it's an appointment, maybe it's further evaluation, maybe it's changing the protocol. So what should you expect from a timeline standpoint? When it comes to an embryo transfer, these different protocols take different amount of time. So that means it's not one easy answer. In its shortest form, you typically need to bleed. So that's going to be 1 to 2 weeks after your egg retrieval. And if you're doing genetic testing, we have to get genetic results back. Typically say there's about a month where we have to get everything ready. We need to do a uterine cavity evaluation if that has not been done, like a saline sonogram. We need to check for polyps or anything inside the uterus that could impact implantation success rates. We also want to make sure blood work is optimized, things like thyroid, vitamin D, that you're in a good place to be pregnant. And then we have to start if there's any lead in to the preparation. Maybe there's not, and it's a natural cycle, and you're going to call us with the next day number 1. Maybe we're going to start you on Lupron so that we can get that suppression underway. But in its fastest, it takes about 2 weeks to grow the lining and then around a week of progesterone exposure. And I'm simplifying this, but let's say 3 weeks from the moment we're starting things going until an embryo is getting in your body. So you have a couple weeks to wait, a month of prep, 3 weeks till your transfer, and then you still have to wait because the day we put the embryo in your body, you're considered 2 weeks and 5 days pregnant. The embryo's at that 5-day stage. We kind of walk backwards to when your fake last period would be. And so you still have 9 to 10 days until you would get to when you can take a pregnancy test. So your 2-week wait is a little bit shorter, but it definitely still exists. So that's longer than most people think, meaning I tell everybody expect 2 to 3 months to get through that transfer process before you get that positive pregnancy test. If we can make it faster, we always will. And I want you to kind of roll into this with the mindset that it will take longer and then we'll be happy if it's faster instead of being in the other position where what if it's taking longer and where you're really frustrated. When should we start to think about what to do next if things aren't working, or what questions should we be asking? An important consideration is where you are and what your goals are. How many euploid embryos you have, how many children you want. Sometimes we do a transfer and our game plan is if it doesn't work, we might actually go back and get more embryos from an IVF cycle. So that's something to consider. Sometimes it's we're going to do the same protocol and choose a different embryo. Sometimes it is we're going to change the embryo. When you're not having success, here's things that I think about. And this is more in the recurrent implantation failure, which is defined as 3 euploid embryos that have not had success. But depending on your full scenario, if you've had pregnancy losses before, these are things to always bring up earlier. Do you have any concern for inflammation, autoimmune disease, endometriosis, adenomyosis? Bring those issues up. Could you have any autoimmune thyroid disease? Could you have any clotting disorders? Could there be anything in your uterus preventing implantation? Index of suspicion even higher if you've ever had anything in your uterus before. Any pregnancy losses, any children, any placentas, any IUDs, any fibroid removal surgeries, anything inside the uterus ever. Index of suspicion, there could be some scar tissue inside. And I've certainly had patients who had seemingly a benign history go in and we do a hysteroscopy, which is a camera inside the uterus where we look around and we might see scar tissue that is hard to detect on a saline sonogram. Remember that a saline sonogram is an ultrasound evaluation of the uterine cavity, and it's fabulous, but it's not perfect. It's a screening test. My rule of thumb is it has to look perfect or you're going to hysteroscopy. But you would be surprised how many people get into an embryo transfer without ever having the inside of their uterine cavity evaluated. And then we end up finding a polyp or scar tissue or something that we could change, which is great. But it's really frustrating to know that you put embryos inside an environment and it had a lower than normal chance of success. We also see a lot of autoimmune disease that hasn't been diagnosed or signs of adenomyosis on ultrasound that are really evident. And we know that if you do have adenomyosis or known endometriosis, you need that Lupron in your protocol. When you have known endometriosis, uterine surgery to remove that endometriosis prior to transfer or doing an embryo transfer with Lupron had the same success rates, but significantly better than if you do a normal transfer without Lupron or without surgery. Some people want to go to surgery because they want the answer or they have significant pain that's interrupting their life. And I am completely supportive if that is you. But for others, that might just take even longer on their journey to getting to where they want to be. And doing a protocol where we're changing that inflammatory environment with Lupron makes more sense. So talk to your doctor about this. It doesn't mean we always have to get to the answer, but we have to be thinking about what the answers could be and making sure that we're treating you appropriately for those circumstances. And that sometimes is where I see that people lose their way. When it comes to what you should be doing, we always want to think about making sure that you have the lowest inflammatory environment possible. It means we want to make sure that your body is ready for pregnancy. We're asking your body to do this really big, incredible thing. So that's going to be getting enough sleep, making sure that you're building muscle, moving your body. In fact, after embryo transfer, women who were sedentary had poor outcomes than women who were active and moved around. That doesn't mean you need to go run a marathon, but it definitely means just sitting around all day long is not what you need to do. We also want you to be eating a diet full of whole foods, fruits and vegetables, high in fiber, because that is the anti-inflammatory diet. And taking good care of your mental health in this time period. I do have a whole episode on the 2-week wait specifically talking about strategies because this is emotionally complex and challenging. My general approach is to let people in to support you, build in stress relief protocols, but also come at this where you know you're doing everything you can. You trust your team, you trust your protocol, you're living the most anti-inflammatory life you can. Therefore, this is going to play out the way that it should, and you are really in the position of power, taking control of this instead of just letting this happen to you. And then lastly, what to expect on transfer day. So on transfer day, you tend to come in and we want you to have a full bladder. This is because we're using an abdominal ultrasound on embryo transfer day, and your bladder is going to do 2 really important things. It actually changes the angle of your uterus. So for most people, the uterus is angled upward in your body and a bladder is in front of it. And so when your bladder is full, it pushes your uterus out, makes it a straighter line and an easier transfer. The other thing is that the ultrasound is sound waves. So when you have more liquid, the sound waves are going to pass through that better, and we're going to get a clearer image of your uterus and the uterine lining. So we want you to come with a full bladder. You'll be taken to a room. You'll talk to an embryologist who should review the embryo with you, show you a picture, make you sign off with name and birthday. Then we'll come in. We place a speculum in the vagina and see the cervix, clean off the cervix with the culture media, the same media that the embryos like to grow in. Just get rid of any cervical mucus or any medication that might be hanging out at the cervix. And then we take a catheter and we place it through the cervix while we watch with ultrasound. And I always describe this catheter like a plastic straw. So imagine I've got a little plastic flexible straw that I'm placing through the cervix right to the entry portion of the uterus. And then once I've gotten past the cervix, which is the most difficult part of the journey, I am now ready for the lab to bring me the embryo. And the embryo comes on a flexible inner catheter. And this I like to think about like a cooked spaghetti noodle. So now I'm going to feed this cooked spaghetti, which is loosey-goosey, through that flexible straw. And then it's going to get right into the inside of the endometrial cavity. And I can advance the little cooked spaghetti noodle and deposit the embryo about 1 centimeter away. So it's very specific from the top of the uterus. The lining's really fluffy there. It's like putting it into Jell-O. It will stick. We'll take the catheter out. Pretty standard to have the lab inspect the catheter to make sure there's not a retained embryo. A retained embryo is when an embryo gets pulled back into the catheter. And so if an embryo is retained, that can happen just from suction and pressure. We want to just replace it in your body. But if the embryo is all clear, meaning inside your body, we're going to then take the catheter out. We'll let you get up and go to the bathroom right away. There's no reason for bed rest immediately. And then we want you to have a good day afterward. There was a fun study showing that pregnancy rates were higher when you were laughing in the recovery room afterwards. So watch a funny show, go for a walk, eat delicious food, try to take the day off just so you can have better mental health. And I always like to say at that time, you are pregnant until proven otherwise. You'll be waiting your 9 to 10 days for your pregnancy test. You'll be taking progesterone, all your medications, make sure that you continue to take them, and make sure that you get your blood HCG level with your clinic, because sometimes home urine pregnancy tests don't detect really low levels. And even though the higher your HCG is, the better the outcome likely is going to be for having a clinical pregnancy. I have had very low HCG levels rise appropriately and turn into beautiful babies, levels as low as 7 and 11. So even if your level comes back really low, that does not mean you're out of the game. At this point, the rate of rise becomes most important. And that HCG should double about every 2 days. So now you'll get an HCG level once. If it's positive, you'll get another one 2 days later. We then will do an ultrasound about 2 weeks from then when you're 6.5 weeks pregnant. And at that time, we should see a baby inside the uterus with a flicker of a heartbeat. You tend to get 1 to 2 more ultrasounds throughout the early first trimester, and you'll continue your medications until about 9 to 10 weeks when we'll take you off of them, graduate you, and you'll move on to your OB. Well, this was the video talking you through embryo transfer, and hopefully this gave you a better idea of fresh versus frozen, protocols and why we choose them, prep work that needs to be done beforehand and what to expect, and if things aren't going right, questions that you can ask your doctor. I know you'll have more questions, so make sure that you can submit them so we can continue to cover things that you are curious about. As always, you can get more information over on Instagram at Natalie Crawford MD. You can also check out the fertility formula, which is my new book at nataliecrawfordmd.com/book. Thank you, friends. Thank you for listening to this week's episode. I'm so glad that you are here. And if you're ready to take the next step in your reproductive health journey, my book, The Fertility Formula, is for you. It's a science-backed guide to understand your hormones, optimize your fertility, and owning your reproductive future. You can order your copy and receive immediate access to the pre-order bonuses that I made just for you. This includes the Hormone and Lifestyle Guide, the IVF course, and access to the exclusive book club with monthly live Q&As. The Fertility Formula is available for sale on April 14th, and I can't wait for you to get your hands on it. Learn more at nataliecrawfordmd.com/book. And as always, follow along at Natalie Crawford MD for even more, because knowledge is power, and your health deserves a formula made just for you as a woman.